Hi everyone. I think that you all know me, but I'll also introduce myself. I'm Joseph de la Fuente, and as you know, I direct the bone marrow transplant unit at St. Mary's, and we will be then talking about research later on in the meeting, which I will also be introducing and guiding. But it is my pleasure to be able to introduce Michael for our keynote lecture today. I don't think Michael needs much introduction because all of us working in the red cell world know him, and it's difficult now to find which organ in relation to sickle cell disease has not been studied in depth by him. He's professor of pediatrics and medicine at Vanderbilt University, where he directs the Center for Excellence in Sickle Cell Disease. But actually the nicer thing about Michael is his efforts in ensuring that treatments for red cell disorders patients, in particular for sickle cell disease, are accessible and available where patients require it, and so has made major efforts to translate high-level research and care into the community setting where the patients live, where it is in Nashville itself or in Africa. And he has also been key in ensuring that hematology is accessible to everybody. So many of you will know of his work in making ASH a fair organization, and where people who traditionally might not have thought of hematology get empowered to do well and to reach the most of the potential. So Michael, thank you very much for agreeing to talking on Priapism, and we look forward to your lecture.
Thank you, Joseph, for that introduction, and thank you for the invitation to give the talk today. I'm going to try this from my house and see if Microsoft does this process justice. Let's see here, PowerPoint slideshow. What can you see?
Perfect. We can see the slide.
Perfect.
You can see the slides. Okay, well, that's great. But all right, so I'm gonna, this is always a little tricky. So I will, it's only on one of my two screens, so you will see the side of me as I try to present. All right, so first of all, for those who know me, this is not a typo. I am going to talk to you about the clinical epidemiology treatment of priapism. And this work is actually being done in Kano, Nigeria, with one of my mentees, Dr. Ibrahim Idris. And he, in fact, could have easily given this talk. And hopefully the next time that there's a discussion about priapism, it will be Dr. Idris who will be the keynote speaker and not me. So the outline is, I'd like to discuss the observation of priapism as a major cause of morbidity in sickle cell disease with no evidence-based preventive therapy. We conducted a qualitative survey of priapism among men with sickle cell disease and men without sickle cell disease. We went on to do a mixed method assessment to understand the impact of priapism on the lives of individuals with sickle cell disease from their perspective, not from our perspective. We've identified a biological plausible strategy for prevention of priapism from the literature as well as from biological models. We have identified a strategy for an internal feasibility pilot. I will share this with you in part because I'd like to get impact or input from you all as to your thoughts about this internal pilot. We don't have funding yet from an extramural source. And then I'd like to bring up a topic that has not really been discussed among the sickle cell or transplant community, but I'd like to make the case that major priapism should be considered as an indication for hematopoietic stem cell transplant based on the data that I'll present to you. So this is a slide that needs really no introduction to a group of hematologists. The main point here is, as you know, sickle cell disease is a chronic disease where hemolysis occurs. As a result of the hemolysis, there's release of arginase, as well as a decrease in nitric oxide availability. This decrease in nitric oxide availability will ultimately be one of the major key points in strategies to offset recurrent priapism in men, boys, adolescents, and men with sickle cell disease. So this slide, I would like to hear some feedback from my colleagues in the UK. This is well known to everyone, this cartogram with the distribution of sickle cell disease in the world. And as you know, there are 150,000 children born with sickle cell anemia in Nigeria alone. There's 1,400 children in the United States born with sickle cell anemia. Of course, the estimate in Nigeria is somewhat suspect in the sense that there is no national newborn screening program. So these are gross estimates. And then in the UK, and this is the best reference I could find, and I'd love it if somebody says, no, there's a better number. And this is 262 children born annually in the UK, not with sickle cell anemia, but actually with sickle cell disease. So this is the multidisciplinary team in Kano, Nigeria. This picture says a lot. I don't actually think it's by accident that priapism has not been addressed as a major morbidity in boys, adolescents, and men with sickle cell disease. Part of the challenge is the embarrassment around discussing priapism. I'll tell you some of the data that we collected from the focus groups, but also there's a lack of interest, quite frankly, where our peers, typically urologists, urologists who are not that interested in the sexual function of Black men. And as a result, there's been really a paucity, disproportionate paucity of research in this area. And the one investigator who in fact has led the field for over 20 years is an African-American urologist from Johns Hopkins, and that's this gentleman here. We call him affectionately Bud, but his name is Arthur Burnett, and it's impossible to read the literature about priapism and sickle cell disease without his name being cited continuously. What you should also note is Dr. Burnett was one of the investigators who identified the pathophysiology of erectile dysfunction, which subsequently led to the drugs to improve erectile function in men. We are hanging out in Kano, and as my Nigerian colleagues reminded me, I do not come to Nigeria wearing a soccer shirt from Ghana. So in terms of sickle cell disease, this is what you all know all too well. There's a lifelong risk of frequent hospitalization, decreased life expectancy. As you all know, just as an aside, we've looked at the life expectancy in men and women with sickle cell disease in the United States and at UNC where Kenataga was, as well as at Vanderbilt where Adetola is the adult hematologist. And the life expectancy in these two comprehensive sickle cell centers was 48 years. Actually no different than the cooperative study for sickle cell disease study that was published 25 years earlier, where the median life expectancy was 48 years. There's a lifelong risk of infection. However, there has been improved survival, particularly in children, where we expect children now to live to adulthood. 99% of those children born today will live to adulthood in just about every high-income setting that's been published. This is attributable to vaccinations, penicillin prophylaxis, newborn screening, blood transfusions, recently hydroxyurea, and then in low-income countries. And of note is that 95% of all children born in the world are born in low-income countries, low and middle-income countries. Just 5% are born in Europe and the United States, in North America. So priapism is persistent, purposeless, and painful erection. There are two types of priapism: ischemic low flow, which is what is most common in sickle cell disease. In fact, it is almost exclusively the kind of priapism that occurs in sickle cell disease. There's stuttering, recurrent ischemic priapism. The average duration is typically less than 4 hours. Major priapism is the real concern for many of our patients, individuals affected with the disease. This duration lasts longer than at least 4 hours. It's time-dependent risk of erectile dysfunction. It's considered a surgical, a urologic emergency, and this is what brings our patients to the hospital when they are informed that they need to come to the hospital. And this point is so important as part of our anticipatory guidance, is to have the conversations with our young boys, our adolescents, and our men with sickle cell disease as we discuss, have you had any pain in the last week or in the last month, we should also be discussing with our families, have you had priapism? And the second type is ischemic, non-ischemic or high flow, which is rare in sickle cell disease. Some of the characteristics between low flow versus high flow, typically the low flow associated with ischemia, as I just mentioned, it's penile pain occurs, and when you talk to the men with sickle cell disease, they will describe they much rather have vaso-occlusive pain in some cases than priapism-related pain. With chronic tumescence without full rigidity rarely occurs. There's also hematologic malignancies that may occur in individuals without sickle cell disease, and so that should be part of the differential diagnosis in managing patients. We typically do not perform blood gases in patients with priapism, and then rarely do you find a history of trauma in this type of disease. So the pathophysiology of priapism has been well established, and it's associated with nitric oxide and phosphodiesterase 5 dysregulation. This is a very difficult concept to understand, and I must tell you, despite having read these articles about priapism over and over again, I really didn't understand the impact of having a low NO level and therefore dysregulation. And I'll have a slide to show you what I believe is a reasonable pathophysiologic mechanism for prolonged priapism. So normal physiology, you have a flaccidity, stimulated nitric stimulation causes increase in nitric oxide, cyclic GMP, subsequent erection, and then phosphodiesterase 5 results in flaccidity. For priapism, this process occurs on the right-hand side of the screen. There's erection, but there is no decrease in phosphodiesterase 5, and therefore there's no flaccidity. One of the challenges when a young man has priapism is the occurrence of how do you induce detumescence. So the tried and true strategy at the 4-hour mark is the penile aspiration, and this occurs typically in the emergency department, sometimes in the OR under general anesthesia, but it is always a challenging event for our patients, including our young boys. And just recently in Nashville, we had a patient who had a 12-hour episode of priapism, completely embarrassed, didn't know what to tell his mother, eventually told his mother, came to the hospital. They performed this procedure and did not have detumescence. And the question was, what should we do at that point? We ultimately went ahead and convinced the urologist that they should try the procedure again a second time. And in fact, detumescence occurred, and the patient has been better since that window of time. So shunt procedure, obviously I'm not the urologist, but this is just to show you the challenge in managing priapism. This was being considered for this 7-year-old, obviously, which would have had lifelong impact. And so the consideration is an active dialogue with the urologist about what is the best procedure, what should be the timing of the best procedure for priapism, and whether non-surgical interventions can be implemented at the time of consideration of this procedure. So priapism is a significant cause of morbidity in sickle cell disease with limited knowledge about its clinical history and optimal management. So with this in mind, Ibrahim and I, with the team from Kano, decided to have a set of focus groups where we wanted to understand the impact of priapism from the viewpoint of men with the disease. So our hypothesis was that priapism severity had significant impact on physical function, sexual function, and quality of life for men with sickle cell disease, and we used a sequential independent mixed method design. There's a semi-structured interview guide to conduct the focus group discussions, An iterative, inductive, deductive approach was used to code and analyze the data. A biopsychosocial framework was used to understand how do individuals adapt to chronic disease. A social ecologic theory was introduced, which focuses on individuals being embedded in a complex interpersonal, cultural, and healthcare system. And inductively, we sorted the coded quotes by coding category and used the sorted quotes to identify details subthemes. Now, for people who do qualitative research, this all makes sense. I just lifted this from the method section of our manuscript because, quite frankly, I didn't understand how to introduce this methodology, and I'm glad I work with multidisciplinary team where we have experts who devote their life to qualitative methods, which was very important to us when we started this exercise, this important research, because we all had biases coming into the impact of priapism on the lives of men with sickle cell disease. But there was almost no data really describing the impact of this debilitating complication on their life. So here's the conceptual framework in terms of context, lived experiences, and impact. As you can see, sexual desire, demon possession, sickle cell complication, marriage, and sexuality, puberty. The triggers included sexual stimulation, sleep, temperature was unpredictable. Sickle cell education was a major concern expressed by the individuals with the disease. Healthcare providers were often aloof and uninterested, or quite frankly, didn't know what to tell them. As you can imagine, there's really very limited evidence-based data. Education has occurred with advocacy groups within their local region. There's a lack of knowledge and training, as I just mentioned. In terms of impact, I just want to mention that the framework that we were able to identify was that there were interpersonal relationships that were altered significantly by the presence of recurrent priapism. Intimate relationships, family support, peer sharing and support. The emotional impact was significant. There was shame, anxiety, and depression. Sexual function over time was non-predictable. There was some remission, there was some erectile function, and one or two men actually described that this was a sexual benefit to have priapism. Life trajectory included vocation, sleep, and increased cognitive load. So the four subthemes that were identified included interpersonal relationships, emotional, sexual function, and life trajectory. So we used the qualitative data to develop a mixed method assessment in this population that was just recently published in Blood Advances. So the cross-sectional survey included 500 men with sickle cell disease between 18 and 40 years of age, 250 men without sickle cell disease. We had a set of priapism questions. We had a priapism questionnaire that's been standardized. We had the International Index of Erectile Function, which looks specifically at erectile function, orgasmic function, sexual desire, and satisfaction with sex life. And then we analyzed the data with standard statistical methods. So I'd like to give you some of the quotes. Obviously, for a publication, we couldn't put all the quotes into the manuscript or to the two manuscripts, but here are some of the quotes from the men verbatim. The Nigerian man discussed sexual desire as an essential driver of priapism and did so in a way infused with shame and stigma. I used to have this intense sexual desire. Anytime I was in the class with girls, there was a girl I wanted to marry, and one day we were together when my priapism started. I just told her to go home. She was like, "What's happening?" I said, "Just go." I ran very fast and came back home. That's why I think it has to do with my sexual feelings. My father thought my condition had to do with possession by evil spirits. Therefore, he took me to an Islamic scholar who performed exorcism to remove the demons causing it. I had 6 sessions of exorcism within 6 weeks, but with no improvement. So we had focus groups in the US as well as in Nigeria. And so here's the comment from the Nigerian. I later joined the Sickle Cell Club where I discovered the priapism has something to do with my sickle cell disease. Again, there was no discussion about the presence of priapism by the healthcare provider. It was scary at first, but then it was like, it's due to sickle cell disease. So both the Nigerian and Americans men were willing to and able to talk about environmental factors that may trigger an episode of priapism. I finally just lay down and go to sleep like boom, I got priapism that lasted 10 hours. No, not now, not as much. I mean, when the cold weather comes, that's it. It's like a trigger. At a point, I was relating it to hot weather. It's Nigerian, and man, you can take one wrong deep breath and it's there. And this really shows the capriciousness of the onset of priapism from the perspective of men with sickle cell disease, which obviously is a challenge when you're planning your life and you would like to go through the routine activities of daily living. So what was a persistent theme was the absence of informed medical providers about the management of priapism. So both the Nigerians and the Americans stated, I have a lot of priapisms, probably like the last 90 days. I've been in the hospital like 55 times getting aspirations done. Even in the hospital, they would put ice block on my penis, but it would still remain hard and erect. Now, the benefit of an ice pack on a blood flow of an individual with sickle cell disease, I think, would be contrary to almost every hematologist on this call. Nevertheless, this young man received such treatment. They would keep applying ice block and giving me intravenous fluids until eventually it turned flaccid, but it would recur immediately. I go to sleep. So the impact of priapism, as you can imagine, is quite dramatic on one's sexual confidence and emotion. But over the years, this is a quote from an African American, but over the years, I've stopped producing semen, and that's been one of the biggest downfalls of the relationship. Since I'm unable to have an erection, I feel like a useless person. This is Nigerian. My worst experience was when it lasted 4 to 5 days. I was initially feeling shy to tell anyone about it until it reached the extent that I started crying. My father heard me cry and came rushing. That's when I was summoned courage and told him about my situation. This is in Nigerian, and it is a source of great worry for me as it affects even my study. I feel like life has no purpose anymore. These are the quotes. I can tell you, having been to Northern Nigeria multiple times and working with the team, there are cases, more than one, of men having gangrene with sickle cell disease because of the lack of knowledge, therefore the absence of showing up in the emergency room for prompt treatment. So this is an opportunity for all of us as providers to educate our families about priapism. So in terms of the mixed method, here's what we did. It just gave you the results for the 3 sessions in the United States with 7 men, 3 sessions in Kano, Nigeria with 28 men. And these are the focus groups. The data was analyzed using the iterative inductive technique. The results I've just gone over with you. I'd like to talk to you a little bit about the quantitative data now. Let me hit pause. I'm happy. I feel like I've been given a monologue for the last 20 minutes, and I'd love to have some human connection here. Any questions about anything I've said up to this point? I can't see the screen, so if the moderator, Josu, if you could just read the question or tell me if there's any question. If there's no questions, I'll just keep going.
Michael, are you going to talk more about the treatment in the following slides, or can we ask questions at this point?
Well, I'll talk about the treatment as we go forward, but I'm happy to hit pause and listen now.
Michael, I think there are no specific questions in the chat at the moment.
Okay.
Should we pick those up at the end?
Yes. So great. So in terms of the quantitative, the data from the group included the following for the prevalence of priapism. This is 163. This is specifically from Nigeria. There were adults where more than 25 years of age were in the, this is the prevalence of priapism. Sorry, you can see the adults more than 25 years of age had the, I don't want to say the lowest, but the least experience of priapism during the questionnaire period. The young adults, 18-25, by far had the highest onset of priapism, and then teenagers, 13 to 17, had some priapism. But I think what's critical is that the experience of this man is that many of them experienced priapism when they were less than 12 years of age. And so this, again, for the pediatric hematologists, is incumbent upon us to really look at educating our children and their parents about the onset of priapism, really from the start of medical care as a young child. So in terms of impact on mental health, self-image was 87% in terms of the impact of priapism. Sadness, 67%, embarrassment, 62%, fear, 43%, and just exhaustion, fatigue was 38%. I think it's important to note that in this survey, almost half of the men did not seek medical attention. Again, this goes back to the emotional burden. This is the data I just pointed out. But the embarrassment and the sadness, just to show you the relative scale, is a major complication in this comorbidity of priapism, and really highlights our responsibility as healthcare providers to help our men and adolescents and young boys get over this sense of embarrassment and sadness as a determinant of their mental health. So when we looked at the results when comparing this to men without sickle cell disease, we had 250 men without sickle cell disease, again in Kano in northern Nigeria. And then we drilled down on 150 men with sickle cell disease. You can see some of the demographic features that we looked at in this population, and I want to drill down further. So of the men with sickle cell disease, the 500 men with sickle cell disease, the most common presentation was the stuttering phenotype. That's priapism that lasts less than 4 hours. The most common trigger was sleep. And so this is one of the reasons that the men come in the middle of the night with priapism. This is a problem, actually. In Nashville, Adetola and I were made aware of a young man who showed up in the emergency room maybe 20 times over the course of several years, always at night and always treated, but never followed up in a hematology clinic. And Adetola and I were being blamed for why did we not provide the medical care for this individual. Well, it turns out that he wasn't a patient that we saw on a routine basis. Neither one of us had ever seen him because he used the emergency room for relief of his priapism, which was his only manifestation of the disease. Sexual desire activity was not a major trigger for priapism, with priapism only occurring in 9.8% of the men with sickle cell disease, and less than 1% of the men without sickle cell disease in the general population. So the duration and the frequency of priapism in this survey indicated that the vast majority had priapism for less than 1 to 2 hours, or approximately 1 to 2 hours, which is referred to as stuttering priapism. Again, up to 4 hours would be stuttering priapism, so that's about 50+%. But then we had individuals who had priapism over 5 hours, 5 to 6 hours, which is about 9%. And then several individuals, actually 18% of the population, had priapism that lasted longer than 3 days. So this is an important, again, opportunity for us to educate the population. The frequency of the priapism occurred monthly, 31%, weekly, 19%, and daily or every other day was in roughly 17%. Self-treatment was common. What I was completely oblivious to was the use of exercise as a means for priapism to abate. You can imagine the challenges of a young Black male jogging through the neighborhood at 2 o'clock in the morning to decrease his erection. It's embarrassing. B, it's probably dangerous in most neighborhoods, at least in the United States. And yet this is the major approach that our young adults have used in Nigeria to reduce priapism. Cold warm packs was 51% and a shower on 44%. So in terms of medical and surgical management, 85% have pain medication to treat the pain, obviously, to treat the pain associated with prioritism. Obviously, it does not cause any abatement in the prioritism. No detumescence is associated with pain medication. It's really for comfort measures. Anti-testosterone medications occurred in roughly a third of the patients, and then penile surgery occurred in 16% of the patients. So in terms of sexual dysfunction, erectile dysfunction was much higher in the men with sickle cell disease when compared to the men without sickle cell disease. Again, the denominator is 500 in the men with sickle cell disease and 250 in the men without. Severe erectile dysfunction, again, was much higher in the men with sickle cell disease when compared to men without sickle cell disease. Significantly lower mean scores of erectile function was about the same in both groups. Sexual desire was about the same, and then intercourse satisfaction was roughly the same in both groups. So our conclusion from this mixed method approach that was published in Blood Advances is that there's convergence of physical function and quality of life. Complementary and triangulation occurred with sexual function. Our results showed that priapism across cultures is associated with shame and embarrassment. These emotions interfere with timely clinical and family communication about priapism symptoms and complications, and that participants were dissatisfied with the quality of care at emergency facilities, and that priapism impacts on physical function, quality of life, and sexual function. So what should we do to prevent priapism in boys, adolescent, and men with sickle cell disease? So here's the, if you will, buffet of options for prevention of priapism in men and boys and adolescents with sickle cell disease. This list is well known to you. I would just simply say that none of us are convinced that any one of these strategies has been effective in the management of priapism, and it's usually a trial and error process in which you provide the care to the patients without actual confidence that the treatment will abate the approach for recurrent priapism in this high-risk population. If you say to me, well, what do you do in Nashville, at Vanderbilt? What do Anatole and I do? The first is the importance of self-education. We will believe strongly that all of our patients should be placed on hydroxyurea. As many of you know, hydroxyurea is an NO donor, and it is an effective strategy for most of our patients with sickle cell disease prior to the onset of priapism. Now, once the individual on hydroxyurea continues to have priapism that is recalcitrant to intervention on a recurring basis, then we end up transfusing them. And in fact, there's a young man, several young men who have been on hydroxyurea with double-digit MCVs, high hemoglobin Fs, all indications that, not double-digit, triple-digit MCVs, 110, 115, sorry, high hemoglobin F levels, who continue to have priapism. However, when we started the transfusion program, the priapism essentially went away because we didn't want an indication for chronic transfusions to be priapism. We eventually, after about a year, put them back on to hydroxyurea, and the priapisms occurred again, and subsequently this young man had to be put back on transfusions and ultimately received a hematopoietic stem cell transplant. So what about randomized controlled trials? So here's a randomized controlled trial using sildenafil for preventing recurrent ischemic priapism, and I'll talk to you about a little bit about the perceived contradictory nature of starting a patient with sickle cell disease on sildenafil. This was a trial that was initiated by Dr. Burnett at Johns Hopkins. The study design was men reporting priapism at least twice weekly were randomized to receive sildenafil, 50 milligrams of placebo daily that was unassociated with sleep or sexual activity for 8 weeks. This was an open label use of sildenafil regimen for an additional 8 weeks. After the initial randomized trial, the results were really inconclusive, other than the proof of principle that men were willing to take a sildenafil to prevent priapism. More recently, in a non-randomized approach, again, Dr. Burnett elected to look at his experience of using a phosphodiesterase type 5 inhibitor therapy. Again, it's not controlled. Here's the results. There are 24 evaluable patients, of which 22 reported improvement in priapism. The median length of regimented phosphodiesterase type 5 inhibitor use was about 3 months. Treatment resulted in a decrease in ER visits by 4.4-fold, and 17 patients with recurrent ischemic priapism relapsed after treatment. Discontinuation showed significant increase in priapism duration and frequency. Again, this is not something that I would say is the highest level of evidence, and really is just preliminary data to suggest that a phosphodiesterase type 5 inhibitor may be beneficial to this population. So why should a phosphodiesterase 5 inhibitor be beneficial? Well, chronic low nitric oxide levels is associated with dysregulation of normal erection and detumescence in sickle cell disease. And this has been demonstrated in sickle cell mouse models, which Dr. Burnett has published previously. But if you look at this 2x2 table, you can see at least a paradigm to consider what is going on in men who have recurrent priapism. So you have low bioavailability, normal bioavailability of nitric oxide. So when you have a low bioavailability of nitric oxide, you have this priapism which occurs in sickle cell disease, and normal erection and detumescence does not occur. However, if you can increase the nitric oxide level to near normal, you will have a decrease in the rate of priapism, which is as mentioned, diseased state, and you'll have a normal erection and detumescence. So the goal would be, what are the NO donors? What are the therapies that can provide NO as a donor that would potentially improve the outcome of this high-risk population? So here's what's been postulated to occur: the potential synergistic benefit of hydroxyurea and tadalafil. Tadalafil over sildenafil because of the long-acting benefit of tadalafil when compared to the other phosphodiesterase inhibitor. The main point here is hydroxyurea is an established NO donor, and the use of the phosphodiesterase 5 inhibitors have potentially synergistic effects of increasing NO availability in individuals with sickle cell disease. So the additional benefits of hydroxyurea, which are often not described, it's almost as if the only benefit of hydroxyurea is to increase hemoglobin F, but also should be noted, hydroxyurea will increase the total hemoglobin levels. It decreases blood viscosity, namely as a myelosuppressive agent, you have a decrease in the total white blood cell count and a decrease in the ANC. You have a decrease in the platelets. You have a decrease in intracellular hemoglobin S concentration. You also have a decrease in inflammation. And as we now know for the drug cresolizumab, decreasing in the red blood cell adherence to the endothelium, as well as other anti-P-selectin benefits may also be the benefit, may also potentiate the benefit of hydroxyurea in this population. So with this in mind, we decided to put together our, this is Ibrahim and the team from Kano, Dr. Burnett and myself, a global hypothesis for a phase 3 randomized controlled trial in men with sickle cell disease and a history of at least 3 episodes of recurrent priapism over a course of 12 months. Hydroxyurea plus tadalafil will achieve a 60% relative reduction in the incidence rate of priapism recurrence when compared to hydroxyurea alone. Notice that we believe that all men with sickle cell disease should be put on hydroxyurea, specifically the men with hemoglobin SS, which is the predominant phenotype in northern Nigeria. So unlike our previous trials that we have initiated, where there's been a pilot trial first with a subsequent phase 3 randomized trial, we've elected in this particular case to consider an internal pilot. As you know, there's almost no data about what the treatment benefit will be for hydroxyurea plus hydroxyurea and tadalafil. And so rather than starting a pilot where we don't have that information available, we prefer to use the internal pilot. The advantage of an internal pilot is that there can be substantial adjustment of recruitment strategy and study processes as we continue to ask and answer the primary question. So the patients included in an internal pilot can actually be utilized in the final phase 3 trial results. And then the main output of this is a single reassessment of the recruitment and data collection strategy as part of your internal pilot. And this is a wonderful study, pilot feasibility study, that describes the different types of pilots that can be utilized in clinical research. So the initial pilot trial is the internal pilot trial is the initial step to ascertain necessary but not sufficient data for the phase 3 trial. We will ascertain the rate of recruitment, which we do not know, the rate of adherence to the clinical trial therapy, and the rate of the clinical trial retention. As you know, if you have a clinical trial that you don't know how long the patients will stay in the trial, you have a problem. And we have no knowledge about the retention rate, or the converse would be the dropout rate in individuals with sickle cell disease being treated for Priapism. After 3 years, we propose that about 70 participants will be enrolled and followed for at least a year. At that point, we will perform a single interim analysis. We will all be masked to the results, but the point will be, with the statistician, we can refine the final sample size based on the efficacy estimate. Here's the proposed randomized controlled design. This will be done in northern Nigeria, where there's over 5,000 men with sickle cell disease. In Kano, we will approach and enroll 100 participants with sickle cell disease-related Priapism who have met the inclusion-exclusion criteria. The target enrollment is about 4 to 5 participants per month. This will be a randomized trial, 1-to-1 with blinding. Tadalafil will be given at 2.5 to 5 milligrams. Hydroxyurea will be given at 20 milligrams per kilogram per day. As I just mentioned, we will have a feasibility outcome, and then this will be followed by the phase 3 randomized trial. So my last slide is, should major Priapism, at least 4 hours, be an indication for curative therapy? And so just recently for the NIH BMT-CTN, we presented, Dr. Kasim and I presented to the DSMB and the steering committee that in light of the data that I've just shared with you, that Priapism is at least as devastating to the lives of individuals with sickle cell disease as acute vaso-occlusive pain is. And we felt that 2 episodes of major Priapism, again, these are urological emergencies, in the last 12 months, or 3 episodes in the last 24 months, should be a consideration for curative therapy. So in conclusion, Priapism is a major cause of morbidity and sickle cell disease-related morbidity. Biological plausibility to include both hydroxyurea and tadalafil, at least I've presented that, and that with funding support, initiating one of the few and largest internal pilots of Priapism in men with sickle cell disease. We're awaiting a review by one of our funding sources, so time will tell. And the plan is to enroll 100 men with sickle cell disease from a pool of 5,000 in northern Nigeria. Thank you very much. That's it.
Well, thank you very much, Michael, for that excellent talk. And I have to say that independent from you on this occasion, we have just revised the indication for transplantation in sickle cell disease in the UK, and I submitted the new indications on Tuesday, and it also contains Priapism in it for the first time.
Great.
So if anyone wishes to start the discussion, would you mind putting the message on the chat or raise your hands and Ralph will give you way. Michael, may I start? I can see that there is no role in the use of transfusion therapy in your talk for the acute presentation. And that is, I think, how we view it also, but that is what has truly been modified in our practice in the last maybe 5 to 10 years. Do you see an exchange transfusion in somebody in whom you cannot resolve the Priapism?
Yes, And so in this young boy who was 7 years of age, who had priapism initially for 12 hours, and in the morning when I got the phone call that they were going to put in a shunt, I said, wait, please, not a shunt in a 7-year-old. I said, please go back to the urologist, ask the urologist to perform the penile aspiration again. I said, and line up the opportunity for an exchange transfusion to get the hemoglobin S level less than 30%, and then also consider starting this patient on hydroxyurea. And the reason is that there's actually data in blood that the acute use of hydroxyurea has an acute benefit. It's not one that necessarily lasts, that takes 3 months to occur. And so I was throwing all the conservative treatments in first, and exchange transfusion, I think, would have been one of the first benefits if this patient did not have detumescence with the second aspiration. Fortunately for this patient, because we were all on pins and needles, the patient did have detumescence, and they went ahead and did the exchange transfusion anyway because of the concern that it may recur again.
And is there actual evidence that exchange transfusion does actually work in that situation? Or is that something that we do because it's what we do in sickle cell disease?
No, there's no evidence. And there is just anecdote, and there's a study out of Brazil that that there's actually no benefit. So I believe that all of us have been in situations where the absence of a phase 3 trial data has resulted in some hesitancy to use an exchange transfusion. But as we do with every organ failure in sickle cell disease, be it the brain, be it multi-organ failure in an acute circumstance, generally speaking, the only arrow in our quiver is an exchange transfusion to get the S level less than 30%.
And finally, what is the dose of hydroxyurea that you recommend in that acute situation?
I would start off with 25 mg per kg.
So we have a question from Phil Connor, who is one of the main hematologists in Wales. He's actually a pediatric hematologist like we are, Michael. And he wonders whether there is good leaflets or material for information that you have for children below the age of 12 that may aid in this.
Gosh, great question. It's in fact, it's such a great question that I'm hiring a couple of adult young men to work in my lab this summer, and I'm going to put them to this task because, to my knowledge, there's very limited information that we can hand out to parents. I mean, at the end of the day, it's the parent and the child that needs to understand the concept of priapism. The 7-year-old was afraid; he didn't know what to do, and he had priapism for 12 hours. So, great idea, and love to collaborate with any community-based organization across the pond to have this vetted, because at the end of the day, I think we have to have the lens of the child, the adolescent with the disease, and not our lens, because we have failed. We have shown that we have sunglasses on with Coke bottles, lens thickness. We can't see this problem from their perspective.
There are a couple of hands raised, Kofi and then Lola.
Yeah, thanks. Michael, that was a very informative, brilliant talk, as usual. My question is basically around the issue of education of these young men, boys, with priapism in a place like northern Nigeria, Kano, which I've been, in terms of their involvement of, let's say, religious and community leaders, because I think that could be one of the things. Obviously, the stigma issue is quite big as well.
Yes, you hit the nail on the head, and I'm not an expert on cultural and religious impact on healthcare in northern Nigeria. we have recognized that many of the young men will go to the local healer and they will get actual roots and medicine, and at a non-trivial cost to the family. And so at some level, this has to be brought to the attention of the pediatricians, and so that they can educate the next cohort of young boys and their families about this is an expected complication of the disease. A third of the men document that they have priapism. So I think we just have to do a better job of empowering our families to know about the complications. And this is a has to be a grassroots approach. Let me just say that we have done this in stroke, and we actually have videos in Hausa in northern Nigeria around stroke. And what happens now is that the families are made so aware of strokes that they're bringing the children in within hours of focal neurological deficit. So we can do the same with priapism.
Yeah. Thanks.
Lola, I see your hand up.
Yeah, thanks. Thank you very much for a very interesting lecture. My concern is that, this data suggests that as professionals, we're obviously failing these populations, because if we know that it's a very difficult topic to approach for the patients. So therefore, isn't it our responsibility then to always ask about this as a routine question as part of their annual review? And then to, as you said, to make sure that we have suitable materials, educational materials. I know that at our center where Kofi and I work, we have leaflets on priapism, but I don't know necessarily that we have it for the sort of every age group that we should really have it for. And I think your idea of having some collaboration will be very, very useful. But I think it's a failure on our part if almost 50% of the population who experience priapism do not feel able, one, to recognize it, two, to actually discuss it and come forward when they do have that problem. I mean, I know there's the stigma, etc., but I think if we are able to empower them to feel reassured that when they come into the hospital environment, that they're not going to experience, the embarrassments that they think they will experience in A&E department.
Yes, I just should say I agree. This is a concerted effort, right? And one of the challenges, at least in the States, as you can see here from the trial that I introduced, is I have to convince people that this is an important enough problem to study. Mm-hmm. It's not by accident, I think, over the last 25 years, that the best we can do is a trial with 25 adults. Come on, we can do better than that. I mean, and I think it speaks to some of the biases that occur in conducting research in this population, not from the patients themselves. They clearly don't believe that this is a fleeting problem that should just go away. This is a major component of the lives of men with sickle cell disease, major component. And yet our funders, or the people who make the decision about funding, have not embraced this as a problem. So, we just roll up our sleeves and get the work done. And then we need the voices of our individuals who have this problem to speak to this in an open format. It's a very embarrassing challenge, as I'm sure you can imagine. And rarely do you have in these patient-centered conferences. I've never heard a man or adolescent talk about priapism in 20 years. And so we have to do a better job as well.
Yes, I agree. Thank you.
Sure.
Hindatu, you had a question or comment?
Yes, I just wanted to say thank you for the talk. It is actually so informative. As somebody that I don't have any medical background. I'm part of the patient public voice group. I actually have sickle cell myself, and the area that you're talking about is where my father's from. So for me, it's almost like, okay, it's a personal thing, but also I'm here to kind of get information, because even for me, having sickle cell, it's something that, even for my brother's sake, I really haven't involved myself in trying to find out anything more about it until now. I just want to touch on what Kofi said about getting leaders, like faith leaders and community groups involved. But I feel like we're missing something here. Although it's men that you know, they basically have this problem that they're facing. I feel like if the approach, sorry, let me start again. The approach should be the women, actually, they have quite a lot of influence. And although it's the North, where it's quite Muslim communities, I feel like the women in those communities have a lot of say. And I feel like if they are informed about what happens at the beginning when the child is diagnosed with sickle cell, and then interventions continue to happen, those, it probably wouldn't be a problem right now. It wouldn't even be something that we might be discussing. It wouldn't be embarrassing for the men to discuss.
Yes.
Sorry.
Yes. You know, I completely agree. It's the mothers. It's not the women. It's the mothers. Because the mothers are the ones who bring the kids in. But I would be remiss if I didn't mention 2 quick points, and I think they're very important. And again, this has not been highlighted. And I'll be very quick because I realize that we're hitting the hour, but I think these points are important. Number one is women have women-specific health issues with sickle cell disease that are not acknowledged. And for those who are in the public health domain, I'm going to give you a number. You know, in Europe, there's outcry when the maternal mortality rate is in the neighborhood of double digits, 11, 12 per 100,000 live births. That's the way that we describe maternal deaths per 100,000 live births. In the United States, there was an outcry when it was like 25 deaths per 100,000 live births. In Ghana, Sam Apong at Kalibu Teaching Hospital documented that the death rate in pregnant women was 10,000 per 100,000 live births. That's women with sickle cell disease. 10,000. How can this not be an outcry? How can we not be outraged about the level of maternal death in this population? So women have a whole nother set of problems in sickle cell disease because having a baby should not be a life sentence for death. That's number one. Number two is that the second problem that has occurred in women with sickle cell disease, they just is flat out ignored. And the only reason I even bring this up because one day in rounds, there were some people snickering when a young girl came to the hospital, admitted to the hospital, and the people were snickering at her, professionals, because they were saying she's in a hospital because she's having pain with her period. And what it turns out is that when you go through the same exercise of focus groups with women, led by women, you will find out that pain, sickle cell disease related pain, not dysmenorrhea, but sickle cell pain is associated with the onset of menstrual cycle in women with sickle cell disease. And in the focus groups, Diva Sharman, I'll close with this, when she had the focus group with women, they were so overjoyed that somebody actually acknowledged this phenomena that multiple times she was hugged after the focus groups because there was somebody who said, no, you're not making this up. So again, I think there's some bias in the way the health professionals have perceived even pain in sickle cell disease. And the last comment here is that the pain associated with sickle cell disease is so severe that among the women, that there were several women who commented that when they were in labor, they didn't recognize they were in labor because they were always told that the pain was so severe that the pain would be one of the worst things that happened to them for labor. They thought it was less than their sickle cell disease, so they didn't show up to the hospital till late because the vaso-occlusive pain was in no way comparable to the labor pain. It was much more severe, and they had accommodated to the level of pain and were fixated that it would be worse than the sickle cell pain when in fact it was dramatically less. So I think that we have to acknowledge that there are sex differences in the manifestations of sickle cell disease. And we have for the junior people out there, the fellows, the residents, the medical students, there's an open opportunity to understand the difference in sickle cell disease that's based on sex. So I'll close there. I really appreciate your time and your energy. And thanks for inviting me. It's been a great pleasure.
Thank you.
Thank you.
Thank you,
Well,
Michael.
Michael, thank you very much for agreeing to our first keynote lecture. We will remember this. It's been a real pleasure to have you, and we will continue to share in the coming years.
Thank you. Thank you for inviting me. Off to clinic, telemedicine clinic for me. Take care. Bye-bye.
Thanks very much. Bye-bye now.
Bye-bye.
Bye.
Thank you very much. Excellent talk.
Bye.